everyone. Welcome back to Misconceptions. A number of weeks ago, I had the opportunity to listen to a conversation that is done by a wonderful therapist in Lakewood, I believe, whose name is Maishi Norman. And he brings these wonderful experts on many different topics. And I had the opportunity to hear Elan Javanafard. Did I say that properly? I hope, or close to it?
Close. Javanfard.
Javanfard. I was trying to get fancy in Persian, but I missed that one. I'm sorry. Javanfard, who really did an outstanding presentation about suicide. I actually shared the recording to multiple people because it was so good. And you graciously agreed to be in conversation with me today. So welcome, Elan.
Thank you. Thank you for having me.
So I would like to, first and foremost, why don't you tell people a little bit about who you are and your professional work and where you're located?
Yes. So my name is Elan. I generally go by Elan as well. I live in Los Angeles. I've born and raised in Los Angeles, moved out of Los Angeles for my undergrad, where I lived in Israel, and I did my undergrad while I was in yeshiva for 3 years. I was on track I made a decision where either I was going to apply to graduate school, and if I got in, I would go to grad school, and if I didn't, I would stay and go down the path of going into Kollel and becoming a rabbi. Turns out I got into graduate school, and my career led me back to Los Angeles, where I started doing quite a lot of work in the area of high-risk mental health services, particularly suicide, borderline personality disorder, and anything that is on the edge of real clinical distress. Formerly, when I was doing more in-person direct care, I would spend a lot of time actually in the field, going out and seeing people who were actively suicidal, whether that was on a bridge, on a rooftop, wherever it may be. But it allowed me to get the experience of getting trained in multiple different evidence-based practices that had a lot of applicability to different populations, particularly those who are at risk. Some that we'll actually get to talk about today, one that I'm excited to talk about, it's called IPV. Sorry, IPT. IPV is a different problem.
Mhm.
IPT, which is Interpersonal Psychotherapy. But at this time, I'm also a adjunct professor at Pepperdine University in Touro's graduate school. I'm a father of three living here in Los Angeles, and I have the honor of writing for several Jewish magazines in the intersection of psychology and Torah. So I write what we call a psycho-spiritual insights, understanding something from the Parsha with a psychology lens on a weekly basis.
Oh, I like that. Where are those printed?
They are printed in the LA Jewish Home. They're also printed on the Nefesh blog, which is
Hmm.
the organization that does a lot of mental health advocacy and work for the Jewish community. And I'd be happy to share it your way as well.
Absolutely. We'll put that into a link. I think that this conversation, first and foremost, I want to acknowledge that we are going to be talking about suicide. And I have no doubt that there will be, stories that will be difficult to hear. And our intention is not to create any trauma, but to be recognizing that, if this is something sensitive to you, particularly, especially if you have personal experience or firsthand experience with family members, take care of yourself and how you listen to this conversation today. Firstly, I just hearing you describe the kind of clinical work that you did initially, it's almost like the kind of work that nobody really wants to do, right? That's like the hardest stuff. What drew you to that kind of work?
So it's interesting. I actually originally started out in the field of autism. I was doing autism research, completely different field, where I was spending time at the UCLA autism treatment team, where we were looking at genetic markers for autism. We actually put babies in MRIs to look at autism markers. And I was planning on getting my doctorate in autism treatment. And before I did that, my faculty mentor told me to go and try something different. He said, go and apply to community mental health and just try that out. So I looked for the literally closest on GPS location to where I was of a community mental health site. And on the application, they asked me, what population do you want to work with? I said, kids, developmental, families, because I do have a background as a marriage and family therapist. And what population are you not interested in working with? I said, I'm not interested in working with risk or suicide or personality disorders. And flash forward 13 years later, I still work there. I'm in essence, like VP of operations, and my specialty area became 16 to 25-year-old women with a history of cutting and borderline personality disorder. And
Love it.
what I realized was that my hesitation and fear of working with this population was ingrained in me in grad school. This idea of like, they're going to sue you. It's a terrible population to work with in terms of stress. And none of that was legitimately accurate in my experience clinically. What I realized was that all I needed was the training to feel comfortable and confident working with this population
Hmm.
and the ability to have good self-regulation to not carry it home with me on a day-to-day basis. And thankfully, I got both of those experiences and opportunities, which made it a population that I actually enjoy working with. It's a lot more fascinating to me to work with that population than it is with somebody who has what would be defined as less risky behaviors in treatment.
Hmm. Hmm. What do you think are the reasons that I mean, I think we've always been trained of like that's high suicidal risk is a great liability, and like why are we so frightened? That was one of the things that was like my greatest takeaway from my conversation, listening to your conversation a few weeks ago, was like, hey, wait a second, we can do this if we're well prepared and well equipped, and we really can care for people. How do you balance that against what you've been teaching, what you've been taught all the years in graduate school?
Yeah, I think one of the fundamental reasons why I love teaching in graduate school because I'm shifting that perspective from the inside out at this point. But the things that I was taught in grad school was that when you deal with suicide, when you deal with substance use, when you deal with comorbidities, that needs to be done by a specialist or somebody who is not the average clinician. The other piece that we were told is that those populations tend to have more risk and liability. And if you don't want to get sued and you don't want to lose your license, then you are going to shy away or stay away from those populations. And in the world we live in now, where there is a lot more accessibility to therapy, stigma still exists, but there's a lot more accessibility to therapy. People tend to lean towards if I can get paid the same to work with one person who wants positive psychology and somebody else who's actively suicidal, I'm going to pick the one that is not going to lead me to any of my own concerns and risks. And the other big factor of it is there's a lot more weight carried in what you do in the therapy room with somebody who's at risk because you yourself might feel like all those things may be true. I may not get sued. I may have the training to work with both of them, but one of them has more dire consequences in terms of what I do versus the other. So clinicians shy away from that. And then over time, they start being afraid of that population and not wanting to work with it, which further stigmatizes a population that needs our help even more than somebody who might be looking for just advanced or accelerated growth in their therapy space.
Whew, I agree with you completely. I think about the reality, like you said, the consequences. Tell me just a little bit from your own personal experience, like how do you cope with the potential consequences of losing a patient to suicide?
So I've shared this publicly before, and I'm comfortable sharing it here too. But the first client I ever received in community mental health ended up dying by suicide. And to have that be your first client ever is a very interesting experience. To this day, I still remember the client's date of birth, social security number, medical record number by heart. It's seared in my brain 13 years later. But it shaped my experience in many positive ways. And what I mean by that is that I had to set very strong boundaries with this client due to what they were going through and the challenges and complications they were going through in their care. And as a result of setting those boundaries and providing them the gold standard treatment for what they were going through, they fired me, which is often a fascinating experience to experience as a clinician. And in signing off on their discharge summary after not being their therapist anymore, not wanting to work with me, I wrote into their discharge summary that this client is at risk of dying by an overdose or suicide or accidental overdose due to this symptom, this symptom, and this symptom, and that's why we set these boundaries. And when several months later they ended up actually being found dead, it looked like it was either suicide or accidental overdose. There was a morbidity and mortality conference that happened where they went over the case and the chart to see like, why didn't you push back further why didn't you change your treatment plan or why don't you do something different based off of. And in hindsight, they looked and they said, you wrote into your discharge summary exactly what would happen because the client was unwilling to engage in services. You passed the case along to the team in LA County that deals with that type of situation. So you did everything you could. There was nothing else you could have done differently. The outcome was going to be the outcome regardless. And hearing that was comforting to some capacity, that there are certain cases you will do the best that you can, you will do everything that you can, and yet the outcome will maybe still be the outcome.
Yeah.
And it made me feel less of an imposter. It made me realize that I actually still had the competencies and skills to work with this group. But secondarily from that, which speaks to the heart of your question as well, I've always been the kind of person who knew that I could handle more challenging things and can live in that space of grief and difficulty longer than other clinicians or other colleagues of mine. And when I realized that I didn't carry the weight of those feelings as long as other people did, I have a very healthy system in place for my own self-care and my own routine, which is really predicated on my like Jewish living style, which I'll talk about a little bit as well. It allowed me to realize that if I'm good at this and it doesn't carry the weight on me as much as it does other people, that this is my area of work or this is my calling.
Hmm.
And feeling like it's my calling allowed me to double down on not feeling as distressed when things didn't go my way, because I had that internal locus of value related to the space.
I love that. And it's interesting because I think that that actually shows up for me personally. And I work very closely with a lot of stillbirth or termination and severe trauma of loss. And I think there are some people that can hold, and there's some people that just this can't or aren't able to at that time. And so I get that deeply. Um, I would like to start a little bit in on what is suicide. I heard a conversation at a conference. It was actually at the Algutta conference. It was with Dr. Blumenthal and with I think it was Sivi Reader, who was talking about like almost like looking at it's almost like its own identity and its own diagnosis versus a symptom of depression and anxiety. How do you conceptualize it? What is the current research on it? What are you thinking about?
So I heard the exact same talk at the Nefesh conference. They gave it again there. And I did have a really interesting, engaging dialogue with them about that as well. I think similarly, in the sense that while suicide has its comorbidity with certain diagnoses, it doesn't necessarily mean that people who have those diagnoses will be suicidal. And it doesn't
Mhm.
necessarily mean that people who are suicidal or will engage in suicidal intent or behavior have a specific diagnosis. For the purposes of treatment and for the purposes of being able to effectively understand the population, we do tend to put them into these groups where if there are a certain cluster of symptoms that are occurring or a certain cluster of behaviors that are occurring, you are more prone or more likely to engage in suicidal behavior. The piece that I shared with Dr. Blumenthal after the presentation, which he was familiar with, and him and I have talked about previously as well. We co-presented on anxiety at another conference together. Is something that's called the Thomas Joyner model, and I shared this I think previously on a different podcast as well, where there are three main factors that elicit a person's capacity or ability to end up dying by suicide, and those don't necessarily map out or equate specifically to a diagnosis.
Mhm.
So whether it's for clinicians or for anyone who's listening, the easy way to understand these is there's something that's called a thwarted sense of belonging. This is a person feels socially disconnected, they feel alienated, they feel isolated, they feel a sense like they don't fit in with people or they don't fit in with any community, which leads to this thought of I am alone. One big thought. The second factor is going to be what's called perceived burdensomeness, which is they believe that they exist as a burden to other people, to their family, to their friends, to society. And they start feeling like others would be better off if they were not around. Not necessarily yet dead, but not around. If I wasn't here, if I wasn't part of the family, if they didn't have to worry about me. And it leads to this second thought, which is I am a burden. These two thoughts, side by side with each other, persistently, I am alone and I am a burden, according to Thomas Joyner, lead to the desire to die. He wrote this wonderful book called Why People Die by Suicide, where he posits in that book that over time, a person who feels this low sense of belonging, this perceived burdensomeness, starts to have this desire to die. And that's where suicidal ideation comes from. The third piece that he talks about is what's called an acquired capacity for suicide, which is they did develop this physical or physiological or psychological ability to overcome that instinct for self-preservation. You stop taking care of yourself. You stop caring about how you look. You stop caring about how you feel. You don't care if you eat or you don't eat today. And you start to have this feeling of like, well, if I'm already sleeping for 20 hours, what's the difference if I slept for 24 hours, which means I don't exist anymore? And over time, that third thought sets in, which is I'm not afraid to die.
Mhm.
When you take these three factors, I'm alone, I'm a burden, and I'm not afraid to die, that's when a person is at risk for a suicide attempt. And when you look at these three factors, it doesn't necessarily reflect any particular specific diagnosis.
Right.
A person can experience all three of these factors due to a stress disorder, which is not what people assume suicide comes from. They assume it comes from a very vegetative depression or a very strong major depressive disorder. So seeing it as its own model of symptoms has shown to be more effective in catching it before it becomes a suicide attempt, rather than just trying to see it through the lens of which specific diagnosis is most at risk.
Mm-hmm, mm-hmm. It's interesting because I'm thinking about it through the perinatal lens, and the one that always like makes the hair stand up on my neck is the one of like, I am a burden, or they would be better off without me. And my baby doesn't deserve this kind of mother. That's where it shows up in my population. And to me, that is probably the most suicidal statement that I have heard, which makes us quite concerned. And that lack of community, I'm wondering, especially because we know that there's so much isolation right now, where people are feeling less connected. And with all the social media, they're still not feeling a sense of community. And I think probably we are attributing a lot of it to COVID, of like where people kind of fell away from communal experiences and then never really rejoined, right? Many of our schools are quite empty. Our congregations are empty. People are just not coming back in the way that we thought they would, or the way that they were there before. So it's just something to think about. That perinatal person, that postpartum person is really, can be actually physically very much alone and not feel like they're in community. They're home, they're taking care of a baby, they're postpartum. Like that aloneness might be something that kind of stirs the pot quite a bit of all some of these other how some of these other emotional experiences. So when you think about like what is your approach? Like when you're thinking suicide and you know that somebody is, suicidal or beginning to express, I guess you're probably approaching before they're actively suicidal. Are you intervening at step 1, 2, and 1, 2, and 3, or all of them being kind of parallel? But
Great question.
what's your approach?
The hope is you're intervening prior to the full-fledged setting in of that thought of I'm alone or I'm a burden. There are what we would call kind of like pre-existing symptoms that a person gets to those thoughts will experience as well. We know things such as helplessness and hopelessness. We know the perseveration that people will have, and the one that is oftentimes under treated, but really can become a hallmark symptom for this type of thinking, is something that's called mood congruent memory. Mood congruent memory, if for those who aren't familiar, is this idea that like when you're in a really, really happy mood, you think of other happy things. And when you're in a really sad mood or in a bad mood, all you can think of is other bad things. And it's hard for you to see outside of the whatever colored glasses you are seeing, the sad glasses or the happy glasses. The example I use frequently when I explain it to clients or other people is that like when I spend time with my high school friends, I act like a 16-year-old because I fall into that groove with them. And when I'm around people for an extended period of time who are sad and all they can think of is sadness, then other sad things start to pop into my head to confirm and have that conversation. So one of the precursors to thinking I'm alone and I'm a burden, and oftentimes I'm not afraid to die, is that feeling where all that I can think of is the bad. All I can continue to remember is the bad. None of the good things are things that I can stick to and remember. So we try to catch that symptom early enough before it turns into the burdensomeness, the hopelessness, the loneliness. And the part that I think speaks specifically also to postpartum in this space is that one of the parts of symptoms of suicide that speaks to many people when they are endorsing suicidal ideation, something that's called psych ache. It's physiological pain in their body due to psychological symptoms.
Mm-hmm.
Now, a person who's going through pregnancy, I can't even fathom and guess how painful that is, and the experience of giving birth, and also after, your body's not the same. You're feeling a malaise physically in your body. You're feeling lethargic. You're feeling more tired. You're feeling more wonky. You're feeling different parts of yourself that don't feel like they did before you had pregnancy or even before you had the birth. So you're already physiologically compromised. Your physiological compromisation coupled with just a few mental health symptoms may start to give that feeling of psych ache faster to a person who went through something painful physically than somebody who never went through something painfully physically.
So it makes you more vulnerable. It gives you a greater, higher level of interesting, a very higher level of vulnerability, which also speaks to me of when there's especially birth trauma, like that would be the ultimate of, or one of the high levels of exposure to a physical experience that can move you into that space of psych ache or of the psychologically compromised experience because of not only the trauma but the physicalness of that experience of that trauma. Very interesting. Very interesting.
When people talk, I've listened to some of the episodes of your podcast as well, but when people talk about maternal mortality, you hear a lot about like hemorrhaging, preeclampsia, infections, but people really overlook that mental health causes are a large factor here. That suicide is one of the leading causes of death in the
It
first year of
is.
postpartum.
Yeah, I want to
Like,
repeat that. Suicide is one of the leading causes. It is the leading cause of death in postpartum. Sometimes that is related to substance use and substance disorders and overdoses, but there are other factors as well. Yeah, yeah, it's huge. Much to consider in that conversation. So, one of the things that I wanted to pose to you as a clinician, as a question, because this is kind of the thing that I think we're like facing as a group, especially in my practice, is the conversation of what, it was always like if you're having suicidal ideation, any plan and intent, you've got to run to the hospital. They have to be hospitalized as you put into the hospital. And on one hand, I think I don't know that has changed at all, but I had a feeling from you that there's a lot that can happen before hospitalization when somebody's experiencing suicidality or that there's this despair of life that might be showing up. Can you talk to me a little bit about what your personal work would be in trajectory before hospitalization, before we would enforce a Baker Act, right? Or whatever state you live in that, against their will hospitalization, which by the way, I think we're finding in many ways is harder and harder. Like we know that someone's actively suicidal, they have a plan and they show up at the hospital and they don't take them into inpatient. So all this hard work that the therapist is doing is really kind of just creating ill will between them and the client. What's your vision of what that trajectory could look like from a therapist perspective?
I can summarize it in two words and then also elaborate on it. My vision is what's called imminent risk. What I mean by that is when there is imminent risk, which means you know that right now they are not going to be able to keep themselves safe till the next time I see them, or even the next 24 hours, that is when I move towards hospitalization. I take more of the approach where everything else in between that can be managed, or you can try to manage it in an outpatient environment. So example of that I give for that is that there are people who will have passive suicidal ideation, thoughts of like, I don't want to wake up tomorrow morning, or thought that I've had myself every time I drive in New York or New Jersey. I've never been on a bridge before. So every time I drive on a bridge, I think to myself, what would it be like if I drove off this bridge? That's fascinating. Now that's not active suicidal ideation. It's not passive suicidal, but it's a thought of what death would look like. There are people who live with passive suicidal ideation indefinitely and can be in outpatient treatment ongoing and do fine. The area where risk starts to come in is when the person has passive ideation, but that couples with a plan or an idea of a plan of how they would stockpiling medication, doing something like I described, going to a roof or a bridge, having access to lethal means, having access to a gun itself is a whole other category of discussion. But when a person starts to go from they have ideation and they've had a thought on a plan, that's when you want to be a little bit more mindful of spending time focusing in treatment on these areas that we've described. Where are they a burden? Where do they feel alone? How do I minimize those things? How do I get them to feel less like they're alone, less like they're a burden, and get support from me and the people around them? And sometimes even medication. Medication may be indicated at that period of time. When the third component comes in, which is the three areas that are needed for hospitalizing someone in any state, plans, means, and intent. The intent is, I now want to do it. The question that gets asked, especially in states like the East Coast or in California as well, which tend to not have as many beds available too, is it imminent risk? Is this a plan that they're going to actualize on today or tomorrow? Or is their plan only going to materialize 10 days from now? Well, if it's going to materialize only 10 days from now, we're not going to hospitalize them because you or someone could have 10 days to offer them some additional support. So in that space where there is that ideation that a person has, a little bit of the plan in place, they can continue to remain in some outpatient services. They can continue to remain connected to a therapist who is actively working on these areas of concern with them. but possibly adding on some antidepressants or getting them connected to medication in people who are willing to take medication. When they get to that threshold where it's imminent risk, where it's, I don't think they're going to be able to make it to my next session. I don't believe they have a plan in place. They're not going to be able to contract for any form of safety with me. That's when we want to start moving towards possible hospitalization. But anything in between, where you try to hospitalize somebody a little too early, oftentimes backfires. It leads to a massive rupture in treatment. It leads to their inability to come back. And oftentimes it leads to them not being willing to share with you in the future, even if they come back, what they're feeling out of fear that you may attempt to hospitalize them again.
So one thing you just brought up, the idea of contracting for safety. I feel like we've kind of like tossed that one out the window a long time ago. I want you to define, because I know you don't mean it the way
Sure.
that we were trained in it. But
Yes.
talk a little bit about what that means, that contracting for safety. I know it means something differently than what we learned about it 20 years ago.
Yes. So the way we like to define it is that a person's ability to share with you what their coping mechanisms are, who their emergency contacts are, people that you could be in contact with if you need to discuss safety with them. And in essence, instead of the word contracting, the more appropriate word now is committing themselves to returning to treatment or committing themselves to working with you. So if they're able to say to you, I'm committed to coming back, I'll see you next time, or I'm committed to checking in with you in 24 hours, that gives you the clarity you need to be able to let them leave your office safely. But if they are unable to commit to that, i.e., contract to coming back or seeing you again, then we don't go down. Then we may sit a little bit longer with that risk. It's not in the lines of, let's have you sign a legal paper saying you're not going to do something to yourself. Because in the end of the day, by the way, those don't even work
Right.
clinically, and they're not legally bulletproof. You
Right.
big
Right.
problem if you actually give that to somebody.
Right. Yeah. I just want to call out the Stanley Brown safety plan. And I know that OHEL, an organization in New York, put together, I picked it up at the conference. I'm sure you saw it. I'm going to hold it up on the screen. It was such a beautifully done document. And it's really things like safe people I can reach out for help, professionals I can contact to help me cope, ways to keep myself and my space safe, some good ways to take my mind off my problems. It's like more of like a, almost like a safety planning tool, which I thought was just very clever. What I'm wondering about is one of the things that comes up a lot that I hear from clinicians is like, I think that the client needs a higher level of care. What does that mean to you? It's not, hospitalization is not relevant per se for this client, but we're clinicians in private practice and they're like, I'm not sure I can work with this client because I think they need a higher level of care. Is that a misnomer?
I think it's a misnomer in the sense of the way people use that term, but there are people who do need a level of care beyond what may be offered in outpatient. But I think the gap between what they believe that is and what I believe that is as large as the Grand Canyon.
Okay.
Um, so for your audience as well to know if they aren't familiar, there are multiple levels of care and treatment. What we like to call individual treatment, once a week therapy with somebody, or OP, regular outpatient services. The levels beyond that, in between hospitalization, are quite extensive depending on the communities you live in. There are things that are called IOPs, intensive outpatient services, where instead of me and the client seeing each other once a week or speaking once a week, they may be in supplemental services throughout those days of the week. So they have a therapy appointment on a Monday, they go to a group on a Tuesday or a Wednesday, they engage in other services as well. There are other levels beyond that as well, called partial hospitalization programs, where there are several hours a day, maybe 3-4 hours a day, in some kind of intensive services and groups, intensive case management, intensive therapy services available for them as well. Many clinicians believe that if my client is experiencing a certain level of symptoms, let's just call it passive ideation and possibly a plan, but they're not at any kinds of means. The clinician assumes that if the client has more touch points with other therapists, that will minimize their symptoms or make their symptoms not at risk as much anymore. And me as a clinician who's seeing them only once a week believes that they might do better with more support for them. Now, in the case of a person like I described who has some of these passive thoughts and a little bit of like thoughts of risk, that isn't necessarily true, because getting them connected to someone else or trying to get them to connect to someone else will make them feel like you're pushing them away. And you
Mm,
are the person that has now started to tell them, hey, you are becoming a burden to me
Ah,
as a therapist.
yes.
You
Yes.
are confirming that thought of you are a burden even to your therapist. Imagine that. Like, I already feel like I'm alone. I already feel like I'm a burden. My therapist says to me, I need you to see other people. You are a little bit, what you're dealing with is a little
You're
bit
too
too
much
much.
for me.
You're
Mm-hmm.
too much for me to handle in outpatient services. The client
Mm-hmm.
has now internalized that I'm alone, I'm a burden. So it can exacerbate the problem to some capacity. And my recommendation, instead of trying to send someone out of services, is to find adjunct services to augment your therapy. So, can I have you still see me, but can I push you towards getting into some kind of support group? Can I push you towards including some additional contacts in your treatment setting with me? Is there a collateral that can come to therapy? You and I and the collateral can talk about what you're going through, so they can reach out to you and touch base with you throughout the week.
That
So
could
it's
be a friend, it
bringing
could be a family member, a spouse, a parent, right? Okay. Mm-hmm.
it could be a communal support, whatever it
Mm,
may be as well. If I'm bringing more people in, then what I'm doing is the opposite. I'm showing you, look at all these people who don't feel like you're a burden to them. Look at
mm.
all of these people who show you you're not alone because we're all here with you. So it ends up doing the exact opposite of what may be the risky behaviors, but keeps them in an environment with you as the clinician.
Hmm. That's what I was getting from you. Was kind of like when we outsource and we push away, we're really denying care to somebody who needs it the most in some ways. I mean, so it sounds to me, and correct me, in the language, but it sounds to me that if somebody is actively suicidal, I'm having all these thoughts of suicide and of hurting myself, ending my life. I know that I would just I have a bottle of Tylenol and I'm gonna just swallow a bottle of Tylenol and I have a big bottle from Costco and you know what? There's like nothing for me to look forward to and I could actually imagine myself doing it this weekend. That person would be more likely somebody that you would say, let's get you into the hospital to help keep you safe. But if
Yes.
somebody says, I know that I could take a bottle of Tylenol, I don't want to, or I'm having a hard time with all these thoughts that I'm having, or I really like I feel so alone in my experience. And yeah, I'm having these thoughts of ending my life. I don't want to, and I'm trying to think of some of the other wording that we would hear. I have it, but I wouldn't use it. Where there's no formal intent, there's no imminent risk. That
Ambivalence.
person, the ambivalence about, oh, so we're listening for that ambivalence more than anything else. And so when we
Yes.
hear that, that should be a cue to us as therapists to say, hold on one second. Let me open the doors and see who else I can invite into the room in terms of social supports and maybe even rabbinic supports and communal supports and support services, so that this client is less alone, more aware that they are a valued member of our community, and not so isolated in their own thoughts and feelings.
Think,
Yes, accurate.
exactly. Statements
Okay.
like, thank you so much. Like, wow, I can't believe you felt comfortable enough to share that with me. Thank you
Mm-hmm.
so much for giving me and telling me these things that are so challenging and difficult to have shared. And now that you've shared them with me, I want to let you know you're not alone. You're here. We're working together, and this is the exact type of stuff we want to do together. How would you feel if we started bringing other people in to learn a little bit more about what you're going through so they also could let you know that you're not alone
Mm-hmm.
and bring more in rather than send them more out?
Mm-hmm.
When they are at that precipice of they're a danger to themselves, they have plans, means, intent, and all of those descriptions that we mentioned, even at that point in time, there are other things that can be done prior to hospitalization. You call their emergency contacts, you try to get to see if they want to go to a voluntary hospitalization. You try to kind of increase services, and hospitalization is that last resort.
Mm-hmm.
But the moment the person tells you that these are the thoughts and feelings I'm having, and I'm letting you know because I want you to be aware of them, that itself is ambivalence. And I told
Mm-hmm.
this to somebody. Somebody called me to consult about a case. I can't remember. It was not that long ago. Maybe it was recently. Um, and said the client is telling me about the fact that they're stockpiling medication or they want to stockpile medication. Client's telling me they're feeling overwhelmed by their job and by their spouse. Um, and and the client comes every single week to therapy, stays for the entire time, never misses an appointment, never is late, always lets me know if something coming up for them in terms of they're going to be 5 minutes late or they're going to miss. So I said, so what you're telling me is this client has never missed a therapy appointment in 6 months, consistently shows up on time and utilizes all of the time you have effectively with you. But they're telling you these risky things. The fact that they keep coming back in its own right means that they're ambivalent and they're not in a place where they need somebody other than you. Because you are the thing that's keeping them going because they keep showing up and keep coming back. If they were flighty in therapy, if they wouldn't tell you when they'd missed, they would just start ghosting you, and they were telling you these ambivalent statements occasionally, yeah, that may increase my risk, but their behavior is not indicating that they're at the level that hospitalization or a higher level of care is indicated. Their behavior is indicating the contrary. They enjoy and they appreciate what you are doing for them. So keep doing what you are doing.
So can I ask you one thing to confront one thing that you keep saying is like, there's so much, how I hear you describing is like, there's a lot of responsibility being held by that therapist. Like you're the one who's holding them there. Your relationship with them is the most valuable and critical to them. And in many ways, you might be the one who's actually keeping them alive. When I hear that, I know that especially some of the younger clinicians are kind of going, that is way too much responsibility for me. A senior clinician might be like, okay, so can I tolerate that? And you discuss that ability of like self-regulation, that I can tolerate the fact that there's a huge responsibility here. And I'm wondering how you talk about that with up and coming professionals or how you navigate that.
Yeah. So one of the effective ways that we validate it first, that yes, there is more, we do know there is more responsibility with individuals who are in this space. And oftentimes there is, when treatment is successful, more of a feeling of, of the amazing power of what we can do within our space as well. So you have to be in that space of understanding that there is a little bit of both. It is slightly more of a responsibility. We irreverently sometimes will even say to some early professionals that, why don't you feel the same level of responsibility with a 20-year-old when you being their therapist now for the fact that they're going through some dating issues is going to impact the trajectory of the next 60 years of their life.
True.
We talk about how like we forget the responsibility we hold in many other places and we assume higher level of responsibility here. But what we push forward with is that your relationship with the client should not be just solely for the purposes of keeping them alive. Your relationship is to use it to get them motivated for change. From a DBT lens, I believe in this concept that's called the dialectic of validation and change. Which is I validate you, but my purpose of validating you is to help you move towards change.
Yes.
So I validate you by saying that our relationship is an important part of who you are. And just as you were able to create a relationship with me, you can create a relationship with other people that will make you feel just as good in the future, that I'm not a burden, I'm not alone piece of treatment. So I use the relationship to push you towards change. If I just validate the relationship and say like, yes, I'm here for you, I'm the one who will always be there for you, and double down on that piece of responsibility, that is ineffective. You use it for the purposes of getting them to grow.
Which also I think is in many ways professionally protective to you as a therapist, that you recognize that, yes, you hold this certain power and a certain responsibility, and also so does the client, right? The client has choices to make about whether they are going to expand their community and open access to supports. Like, are they going to engage in the change piece? I can do the validation, but they need to engage in the change piece. Really, really fascinating. I do want to bring up the IPT because you mentioned, there's two things I want to bring up. Before I go to IPT, I want to just put in one comment here because I think it's important to clarify that there are people, you described like going over the bridge and having the thought about like, what if I drive off the road? That we actually are really understanding that very often to be more about an intrusive thought that can be actually we've seen like perinatal clients who are treated again and again and again for suicidality. And they're like, I don't know why I feel that way, that like, why did I just drive off the bridge? And what would happen if I crashed my car? And like having these intrusive thoughts about suicide that are actually just intrusive thoughts and are not actually suicidal, because the client will say like, why am I having these thoughts? My life is good. I love my baby. I'm happy in my life, but I'm having there can be intrusive thoughts of suicide, and then there could be suicidal thoughts. And so just clarifying that, especially because OCD is so prevalent and often in its first awareness of it in perinatal and postpartum. Just want to bring that up because that was an aha moment that I think many clinicians had a number of years ago. So that's one thing. Let's move to IPT. And again, IPT is one of only two fully evidence-based treatments for the perinatal population. So I was really excited to hear you say IPT and suicide. Tell me more.
Yes. So IPT is interpersonal therapy. IPT, from my understanding of it, starts with this kind of like radical assumption that you're not broken, you're just overwhelmed by the strained system you're living in right now.
Right.
So it was originally designed around depression, but it's become one of the best empirically based treatments for perinatal and postpartum treatment. The reason I find it fitting so well in with this population is because it goes with this premise that depression is not a personal failure. It's a result of major changes in your life without adding on major adequate relational support in your life.
Mm-hmm.
So any major change a person goes through in their life, they have to adjust or majorly change the relational supports they have as well.
Love that.
And when it starts with that premise that like it's not about you, not like you're not broken, you're not nothing's wrong with you. It's that what happened in your life now needs other forms of transitions and support. It conceptualizes this postpartum depression through this lens of like just interpersonal disruptedness. Your life has changed. You are experiencing many new things that you didn't experience before. Role transition. You're transitioning from being a person to a parent. You're transitioning from being you're in control of everything that you do to being in having somebody else in control
No
of you.
control.
No control. You're changing from possibly sleeping well to definitely not sleeping well. You're changing to having more isolation with a person that you're spending all day with, usually the child, who isn't giving you anything back in return.
Mm-hmm.
You're not getting any of those mirror neurons back of like great positivity from. So the research was showing that even though IPT is not specifically a suicide protocol for postpartum, it works really well
Mm.
because what it does is it forces you to identify your social population, your social support, your social circle. It helps you reduce the isolation you have with those people, increase connectedness. It's supposed to help you through treatment improve your communication so you can express clearly your needs in terms of what you want from people. And it helps you decrease the shame by normalizing what you're going through. What you're going through is common. It's common enough that many women have been through this, even those who may not discuss it or talk about it. But we know that it's like what like the research is showing that in terms of maternal suicidality, we're seeing it like 1 in 5
Yeah.
is experiencing some of that experience. So it's highly common and regular.
Well, I would say 1 in 5 women experience perinatal mood disorders. I don't know that one. Do you see it as 1 in 5 women experience suicidality?
Suicidal thoughts at any point in time during the first year of pregnant, the first year of the birth.
Really
Yeah,
fascinating.
I'll
Okay.
send you. I can send you the.
Yeah,
I
I'd
can
love to
send you
see it. No, it's good. I mean, I have
the
no reason
report.
to consider it differently. If it's a high, I think we want to acknowledge that there are those that will experience depression or anxiety without suicidal thoughts, but there will those that will experience depression, anxiety with suicidal thoughts, right?
Right. So
Yeah.
the CDC Maternal Mortality Review
Hmm.
Committee went over the research and looked and found that just like a thought, not even just the intrusive part, it can happen in 1 in 5 people. That
Hmm.
number is just a growth number that happened recently.
Yeah.
I think it will level off a little bit, but this idea that this form of treatment that is focusing on clarifying the expectations in your relationships, making you communicate without feeling guilt or apologizing, allowing you to expand your social network and naming that grief that you're going through in your body of what you just changed, is a really powerful mechanism for treatment.
Hmm.
And I have found it works very well within the Jewish community. It fits in
Hmm.
very well with at least the Orthodox Jewish community because we have higher fertility rates, repeated role transitions, people going from pregnant to birth to pregnant again very quickly.
Yeah.
These shorter intervals of breaks between pregnancy, which increases chronic sleep deprivation during those periods of time.
Absolutely. Yeah.
So that idea that we have within our culture these components that can increase some of these risks, but also simultaneously we have strong communal supports that exist that many other communities may not have as long as our clients are able to tap into them.
Hmm. Hmm.
IPV takes this perspective that like it reframes treatment as like your own responsible way of taking care of yourself. And it's not, and it allows you to connect back to more collaboration, more support, and bring in people to your care rather than feeling the need to do it on your own.
It's beautiful. I love that. And I think we don't have much time left, but I do want to take a few minutes to talk about culture. I think it's a critical conversation. We are going to talk about the Orthodox Jewish culture. There may be others that you can apply this information to, but talk to me a little bit about your understanding of the history. I mean, I'm very familiar with the history of suicide and the way suicide has been kind of like seen as a culture. And I'm wondering if you think that it's shifting or changing in any way. For sure, that there's more of an awareness of it. I think about all the people that I remember growing up with and was like, he just didn't wake up and he had an aneurysm. Like there's no chance that all of those people actually had aneurysms. And I think there was a lot more death by suicide or overdose that was kind of that, like, we're not going to tell anybody because there was so much stigma related to it. But, maybe talk for a minute. I'll ask you to use your rabbi brain for a moment. Give a little bit of an understanding to the community of how suicide is talked about, perhaps in the Talmudic law, and how we have kind of differently interpreted it today as a mental health condition. I'll let you take the lead on that.
Yeah. So we have this concept and this idea in Talmudic law and Jewish law as well, that like life is important above all else, and the idea of taking your own life or taking somebody else's life is a sin, just as much as killing somebody killing yourself is defined as a sin. Um, and when we go a little further down into some of the information in terms of the Shulchan Aruch, which is an area where we learn about like all of the different rules and laws within Judaism, what it discusses and what it talks about, which is something that's actually a misconception that many people have. They believe that a person who dies by suicide or ends their own life is not then going to be able to be buried in a Jewish cemetery. It's a classic, misnomer that many people experience and think about. And what the language there says is that when a person kills themselves intentionally while they are in a state of thinking rationally. Now, as we've looked through much Jewish literature and many of the current Jewish authors who go into this, and many of the Rishonim and Achronim who talk about this, what we realized was that means that if a person is experiencing any mental health symptoms, is experiencing any loss of irrational thought while they are making their attempt, they did not rationally decide to die, and therefore there's no halachic issue with them being buried in a Jewish cemetery. There's no you still sit shiva for them. You still go through the entire process of it because they experienced this behavior due to the fact that they were medically compromised or psychologically compromised. And we're starting to see that this is more discussed in the Jewish community. We're starting to see that people are understanding this better, and they're not viewing suicide as much of as a spiritual failure. To the point where I've even heard it recently where there have been shivas and they have been funerals where the person was willing and able to share that the person died by suicide. Yeah. That it wasn't the aneurysms we heard. And in the work that I do, there were so many times where I knew what happened when no one else in that room other than the family also knew what happened. And I was hearing heart attacks, aneurysm, they didn't wake up when I was there, when I heard of what the case may have been. So we're seeing that, a lot of major poskim these days, Jewish scholars, are supporting psychiatric treatment and understanding that mental illness is not, in fact, a lack of having emunah, which is belief or spiritual belief in God. Mm-hmm. And I shared this with a rabbi that I did a presentation for the RCC, which is the Rabbinic Council of California, on suicide treatment. And I talked about this idea that having belief in God or emunah does not replace serotonin. Like you still need treatment, you still need something, and you need to work towards that. And I'm starting to see it becoming more spoken about, more known, and reducing a little bit more of the shame associated with it. Yes, there is still going to be a lot more shame in this space than any other part or many other parts of the clinical trajectory. Mm-hmm. But we as a community are starting to see it more as something that is treatable, and we also experience it rather than a moral or religious failing that the person went through.
So I love that you said that. And I think also the idea of, even just the word commit, right? So the word of commitment of a crime, we commit crimes. And that's why you heard both of us using the language of died by suicide or died, or ended their life versus they committed suicide. Because even just that term commitment, all rooted in the original founding fathers language of, the laws of this country, it is illegal to commit suicide. And I think some of that language for sure is changing in the psychological sphere, maybe not so much in the legal, but in the psychological sphere, it's definitely moving.
Can
I
I add
think,
one
yeah,
more?
please.
One, because we're doing it, and I think it's an important one. One more that I hear commonly is the client failed their suicide attempt.
A failed attempt. Oof.
Failed
Yeah.
attempt.
Yeah.
Like the connotations of that when a client hears that, or the connotations of a clinician, you
Oof.
couldn't even kill yourself. That's the
Wow.
And we try to never use the language of a failed attempt. The language we use is survivor of a suicide attempt. They survived the attempt. Just that change for a client. I've had clients come to me and say, I've had 3 failed suicide attempts. And I said, wow, you survived suicide 3 times.
Wow. Oh,
That
that's so
reframe
meaningful. Yeah.
is just as meaningful as the reframe of died by suicide versus the committed
Mm-hmm.
suicide piece.
Beautiful. That's so important. I think the thing that I'm hearing from you so loudly that kind of is, it's really like I feeling it in my body, believe it or not. I don't usually say that, but like this feeling of so much responsibility that we not only, not just as therapists, but as humans, have to help others. Because so much of what you said, it's not even when you said to the rabbis, it's not just serotonin, but like there's a real communal responsibility to help people feel less alone. Why are there people in our community who feel so isolated, who feel a lack of belonging, who feel like I'm just a burden to people? Like there's a responsibility that a community holds, I think, and it's a big responsibility, but we really need to be considering like, are there people on our periphery that are, or right in front of us, but let's just say those on the periphery that maybe are feeling alone and feeling isolated and feeling we're we see it in our client population, right? When I'm doing consultation after consultation and they're just like, I don't have friends, I don't have family, nobody's checked in on me, I don't have community, right? I will be honest that there are those that I say, I think there are many people that contribute to that isolation for sure, meaning the patient themselves contribute to that isolation. But the community also has closed their eyes to be like, oh, okay, they're just not here anymore, or they're not participating, or, but this is a bit of a, to me, it feels like a little bit of a call to action of like, who are these people on our periphery and what can we do better? Because we have so many resources as a community. Um, so many amazing ways that we support people. And yet this, we're still losing people to suicide. And I guess we likely will. I mean, because it is something where we may not be able to save them all or rescue them all, but boy, do we hold responsibility when somebody dies by suicide.
I tend to be very direct. I tend to be a little bit more like on the edge of like directedness and treatment sometimes. And one of the things that I actually ended up saying to this group of Rabbanim was something along the lines of that, and I'll share it for this population more, but it was suicide within a person is not the person's problem, it's the communal problem.
Yes.
There's a whole Gemara that talks a lot about the fact that like if there are people in your community who are homeless, then it's an indictment on the community that you allow there not to be homes for them. And the way I think of it is that suicide within a postpartum period is not about a weak mother. It's about a strong woman who's carrying more than the system has helped her be able to hold.
Amen.
That there
Mhm.
isn't enough support, there isn't enough rest, there isn't enough recognition. It's not about how many children the person has, it's about how much support do they have while they're raising them. And the components of the
Yes.
communal aspect of this that it's one of the things my wife does. My wife, first thing she does when a friend has a baby is she sets up a meal train. One of the big things she does beyond that of a meal train is make sure that the meal train is not just for the first month. Everyone is excited for the first month. Most people who are living within our community who already have friends, they have enough food for the first few days or first month. Set something up for after that first month. Instead of offering to give a meal, maybe offer to take the other kids to school one day. Maybe
Mhm.
offer additional supports that are not the support that the person is experiencing. One of the great things that I know my wife does is that when we take a meal to somebody who had a baby, she also brings toys, activities, or coloring books for the other kids. And the idea
Mhm.
is let the other kids be distracted with this so that you could eat a meal by yourself and not feel like
Mm.
you have to take care of the whole family.
Yeah. Yeah,
So
for
you
sure.
increase that type of that support, I think is a phenomenal part of what we should be doing as a community as well.
Yeah. And I will challenge with one thing that I think shows up again and again is many of the helpers are also the people who just had babies. Meaning
Mhm.
when we live in that pronatalist community, it's like who are the helpers who are not also home taking care of their large family. So we have structures and opportunity and much to discuss. This has been a powerful conversation, Elan. Thank you. Tremendous thank you to you for being willing to have it. I learned a lot and know that my listeners will learn a lot from you as well.
My pleasure. Thank you very much for having me. It's a really wonderful opportunity.